Good day, Ma'am Nizel. I am Kathleen Jean Dicagang, the first reporter for Chapter 22, The Infections of Nervous System, together with my two co-reporters. To begin with our discussion, let's start with the definition of terms. We have encephalitis. It is the inflammation or infection of the brain tissue, the parenchyma, that can cause fever, seizure, or confusion. Next, we have encephalomyelitis. It is the inflammation or infection involving the brain and the spinal cord. It is often due to viral infections such as measles or enteroviruses. Then we have meningitis. It is the inflammation or infection of the protective membrane called meninges that cover the brain and spinal cord, specifically the leptomeninges, which include the pia mater and arachnoid mater, typically due to bacterial and viral infection. Then we have meningoencephalitis. It is a combined inflammation of both the brain and meninges that is often severe. And lastly, we have myelitis. It is the inflammation of the spinal cord that may cause paralysis or sensory loss. What is central nervous system? CNS is impenetrable to infectious agents because it is surrounded by cerebrospinal fluid and meninges and enclosed by the bones. We also have blood-brain barrier, which is another structure that protects the CNS or central nervous system from large molecules and microorganisms. This barrier filters substances from the bloodstream, preventing harmful microbes and toxins from reaching the brain tissue. What is infections of nervous system? Infections of nervous system may present with non-specific manifestations of fever and headache that most would consider benign. Clinical cues that will suggest infections of the nervous system include seizure, altered consciousness, or localizing signs. Types of meningitis. It could be bacterial, fungal, or viral meningitis. So first, we have bacterial meningitis. Under bacterial meningitis, we have acute bacterial meningitis, granulomatous meningitis, and tuberculous meningitis. So let's talk about acute bacterial meningitis. Bacterial meningitis is a suppurative infection of the meninges and subarachnoid space with associated inflammation of the CNS or central nervous system. The high-risk groups for development of bacterial meningitis are children between 6 and 12 months of age. It is because their immune system are not fully developed. Common causative agents of acute bacterial meningitis. We have Escherichia coli, which is common in newborns. Next, Listeria monocytogenes, which affects the newborns, elderly, and immunocompromised individuals. We have Group B Streptococcus or Streptococcus agalactiae. It is increasing in the elderly and immunocompromised individuals. Older infants and children, majority of infections were due to causative agent called Haemophilus influenza type B, in which the incidence of which has been greatly reduced due to the availability of the vaccine against the organism. Hence, it is common in children, now rare due to vaccination. And lastly, we have S. pneumoniae or the Streptococcus pneumoniae. It is currently the most common organism that causes community-acquired meningitis in both children over 1 month of age and adults, followed by neisseria meningitis. And we have here a table showcasing the cerebrospinal fluid findings in bacterial, viral, and fungal meningitis. For appearance, a normal meningitis, it is water and clear. For bacterial meningitis, it is turbid. For viral meningitis, it is clear. And for fungal meningitis, it is slightly turbid. For the predominant and types, in normal meningitis, it is all lymphocytes. In bacterial meningitis, it is usually PMNS or the polymorphonuclear leukocytes. And then for viral meningitis, it is lymphocytes, may be mixed with PMNS during first 24 and 48 hours. And then for fungal meningitis, it is usually lymphocytes. And for glaucous, for normal meningitis, it is 2.5 to 3.5 millimole per liter, which is 50% of blood glucose. And for bacterial meningitis, it is less than 50% of blood glucose, maybe markedly low. And for viral meningitis, it is usually normal. And lastly, for fungal meningitis, it is less than 50% of the glucose, maybe markedly low. And then for protein or grams per liter, for normal meningitis, it is less than 40 milligrams per deciliter. And then for bacterial meningitis, it is elevated, as well as for viral meningitis and fungal meningitis, it is also elevated. And for WBC or white blood cell, for normal meningitis, it is 0.5, which is all monoclear. And then for bacterial meningitis, it is markedly increased. For viral meningitis, it is normal to slightly increased. And for fungal meningitis, it is elevated. Two important subtypes of acute bacterial meningitis. We have Neisseria meningitidis and Listeria monocytogenes. For Neisseria meningitidis, this microorganism is also known as meningococcus. It is a gram-negative coffee bean-shaped or kidney bean-shaped diplococcus that is a transient flora of the nasopharynx, which can cause meningitis if it spreads to the blood or brain. The encapsulated types are virulent, in which strains with protective capsules resist the immune system and can cause serious infections like sepsis or meningitis. Inhalation of respiratory droplets among contacts is the main mode of transmission of meningococcus. Carriers can also transmit the infection through respiratory aerosols. So the disease or the Neisseria meningitidis spreads through close contact, coughing, or sneezing. For clinical findings, it begins as a throat infection. The microorganism enters the bloodstream, causing bacteremia or bacteria in the blood, and spreads to the meninges, leading to meningitis. Meningococemia or the overwhelming sepsis, it may occur with or without meningitis. It is a life-threatening infection because it may cause organ failure or death if untreated. Thrombosis of small blood vessels and multi-organ involvement are common in Neisseria meningitidis. Petechiae or purpuric skin lesions appear over the trunk and lower extremities, serving as a K-presumptive sign. While in severe cases, the disease can progress to disseminated intravascular coagulation or DIC with destruction of the adrenal glands, known as a Waterhouse-Friderichsen syndrome. Laboratory diagnosis. For specimens, blood and cerebrospinal fluid or the CSF are the most useful for culture. This bacterium appears as a kidney bean-shaped diplococci found inside polymorphonuclear cells. Laboratory tests such as counter-immunoelectrophoresis, agglutination, or latex particle tests with specific antibodies are used to detect its polysaccharide antigen. For treatment and prevention, penicillin is a drug of choice, though resistance is increasing. Alternative antibiotics include broad-spectrum cephalosporin and chloramphenicol. For carriers, minocycline and rifampicin are recommended. For prophylaxis, sulfonamides and rifampicin are used in cases of sulfonamide resistance. And we have here a figure showcasing the gram stain of Neisseria meningitidis in CSF or cerebrospinal fluid with associated polymorphonuclear leukocytes. And for the second subtypes of acute bacterial meningitis, we have Listeria monocytogenes. For L monocytogenes, they are short, motile, gram-positive bacilli that appear individually in pairs or chains. They are cold-loving, which grow at 1 degree Celsius and can also grow at 45 degrees Celsius and in high salt concentration. It survives in refrigerated foods, which makes it a common cause of foodborne infection. In healthy adults, disease is usually mild or asymptomatic. It mainly infects immunocompromised individuals or people with weakened immunity, such as pregnant women and newborns. For the mode of transmission of L monocytogenes, it primarily through ingestion of contaminated food products. Perinatal transmission can occur during pregnancy or at birth. It has a strong affinity for growth in the CNS or cerebrospinal fluid and placenta. Infection during pregnancy may lead to spontaneous abortion or stillbirth because bacteria crosses the placenta, endangering the fetus. For its clinical findings, in newborns, it may appear as in early onset listeriosis, it is acquired transplacentally, and for late onset listeriosis, it is acquired during or after delivery. In severe form, granulomatous infantis septica is characterized by granuloma and abscess formation in several organs. For late onset, infection presents as meningitis or meningoencephalitis with septicemia. For its laboratory diagnosis is through culture of blood, spinal fluid, or placenta in selective media with cold enrichment. Tumbling end-to-end motility in liquid or semi-solid media helps in identification. Treatment and prevention. Penicillin or ampicillin, alone or combined with gentamicin, is the treatment of choice. Prevention. Avoid contaminated food products and wash raw vegetables thoroughly. Next, we have granulomatous meningitis. It is a chronic type of meningitis characterized by formation of granulomas or the clumps of immune cells, marked by remissions and relapses. Its causative agents, we have Mycobacterium tuberculosis and Cryptococcus neoformans, which is a fungus. Next, we have tuberculous meningitis. It commonly affects children under 6 years old, rarely below 4 months. It appears 3 to 6 months after initial infection, accompanies with miliary tuberculosis. For its symptoms, we have headache, stiff neck, fever, fatigue, and night sweats. For its diagnosis, we have history of TB contact, positive tuberculin test, CSF examination. And then for its treatment, we have quadruple anti-TB regimen. The second types of meningitis is what we call fungal meningitis. It is an infection of the meninges by fungal organisms, mainly in people with weakened immune systems. The most common causative agents of fungal meningitis are Cryptococcus neoformans and Cryptococcus gattii. And then for its others causes include Histoplasma capsulatum and Coccidioides emetis. C. neoformans, it is encapsulated yeasts, a common saprophyte found in soil, particularly soil enriched with pigeon droppings. It is monomorphic, which exists only as a yeast and of low virulence. Mode of transmission. Cryptococcal meningitis is acquired through inhalation of the fungus from the environment. Infection spreads from the lungs to the blood, affecting the CNS or the central nervous system. Then the clinical findings, patients may experience headache, nausea, vomiting, loss of vision, and other neurologic symptoms lasting several weeks. Meningismus or neck stiffness is usually absent in cryptococcosis. Then for its diagnosis, it is diagnosed by CSF examination using India ink or nigrosin stain to demonstrate the capsule of Cryptococcus neoformans. For its findings, it is high opening pressure, mononuclear cell pleocytosis, increased protein, and low glucose concentration. So we have here a figure showcasing the India ink preparation demonstrating the capsule of Cryptococcus neoformans. For its treatment and prevention, we have amphotericin B plus flucytosine for 4 to 8 weeks followed by fluconazole. Then for lifelong fluconazole therapy, for maintenance, it may be required. Then the third type of meningitis, which is the viral meningitis, will be further discussed by Jamaica Bersabal. Thank you for listening.